introduction, and it's been, what, 2.5 years since I've been in a symposium in India, so it's good to see friendly faces and to come back to normality. So I was asked to give a talk on redefining the management of HER2-negative early-stage breast cancer. These are my disclosures, and if anyone wanted to get in touch with me, my social accounts are on the screen. So we know that the incidence of BRCA mutation among patients with BRCA-associated tumors really varies. We know that in patients with hormone receptor-positive breast cancer, it's about 6%. In triple-negative breast cancer, it actually goes up to about 17%. And of course, we've got a variety of percentages across other BRCA-associated cancers. Now, in patients with BRCA-associated cancers, there's been a lot of work looking at the use of PARP inhibitors in these groups of patients. Some of the earlier work actually came out in 2009 and 2005, where we saw back-to-back papers that actually looked at, in preclinical models, the use of PARP inhibitors in BRCA-associated preclinical models. And you can see from the screen over here, BRCA1, BRCA2 dysfunction was profoundly sensitizes cells to inhibition of PARP enzymatic activity, resulting in chromosomal instability, cell cycle arrest, and of course subsequent apoptosis. And this resulted in a number of phase 1 trials that actually showed that in the presence of a heavily pretreated patient with a BRCA1 or BRCA2 mutant tumor, the use of PARP inhibitors in fact did work. And then we saw Professor Tutt's earlier paper that was published in The Lancet in 2020 that looked at the use of olaparib in patients with BRCA1 or BRCA2 mutations in patients with metastatic breast cancer. This was a proof of concept trial that clearly showed that even in a heavily pretreated group of advanced breast cancer patients, we were seeing some decent responses with the use of olaparib at about an overall response rate of 41%. And this led to two important clinical trials in the metastatic setting, the Olympia-D trial and the Embraca trial, very similarly designed trials that actually showed that compared to physician choice of chemotherapy, if you were to use a PARP inhibitor, either olaparib or talazoparib, you were improving the progression-free survival by approximately 3 months. And you also saw that this worked not only in germline BRCA mutations. We saw the TBCRC048 trial that actually looked at the use of PARP inhibition in patients who had either a somatic BRCA1, BRCA2, or a germline PALB2, and you can see some very, very decent overall responses there. So the question then arose, could we effectively use a PARP inhibitor in the early stage breast cancer setting? So let's look at how the whole paradigm of HER2 negative patients has actually changed with the incorporation of PARP inhibition as well as immunotherapy as well as the use of a CDK4/6 inhibitor. So we know over time prognostic outcome of patients with HER2 negative breast cancer has certainly improved. How could we incorporate the use of PARP inhibition among patients with BRCA mutation positive disease to further improve their prognostic outcome? We saw at ASCO last year in 2021, we saw the results of the Olympia trial. This was presented again by Professor Tutt. These were patients with HER2 negative breast cancer, both hormone receptor positive as well as triple neg. They had to have either stage 2 or stage 3 breast cancer. They had to have a BRCA mutation. In this case, it was a germline BRCA mutation. These patients were randomized to receive either in the adjuvant setting post their neoadjuvant or adjuvant chemotherapy, surgery, and radiation therapy to either receiving adjuvant olaparib or placebo. Now, in the patients who were in the neoadjuvant group and they had triple-negative breast cancer, they had to have residual disease. And if they had neoadjuvant therapy and they had hormone receptor positive breast cancer, they had to have a non-PCR and a CPS-EG score of more than 3. In the adjuvant group, TNBC patients had to have more than a PT2 or more than a PN1 disease, and if they had hormone receptor positive disease, more than or equal to 4 lymph nodes that were positive. The primary endpoint of this trial was invasive disease-free survival, with secondary endpoints including overall survival. The median age of this cohort was 42 years, with 60% of patients having premenopausal disease and 80% having triple-negative breast cancer. And you can see from the slide here the baseline characteristics of these patients, you can see 81% had triple negative breast cancer, 62 premenopausal, and you can see about 50% of these patients did receive neoadjuvant therapy. Now, in terms of the results, you've all seen the results of the Olympia trial. You can see in terms of the primary endpoint, invasive disease-free survival, there was a 3-year absolute benefit of about 8.8%. Distant disease-free survival, 3-year absolute benefit of about 7.1%. And initially, when these results were presented, there was a strong trend, although not statistically significant, in terms of a benefit in terms of overall survival, 3-year absolute of 3.7%. We then saw at the ESMO plenary session earlier this year, the IDFS, a benefit at 1 year of additional follow-up. You can see 7.3% at 4 years. You can see in terms of the subgroup analysis, almost every patient, in fact, benefited with the use of adjuvant olaparib, both in the hormone receptor positive as well as negative patients, BRCA1, BRCA2, as well as those patients who received neoadjuvant or adjuvant chemotherapy. In terms of the first IDFS event, you can see that in terms of CNS recurrences, less in patients who were receiving olaparib. Interestingly, there were less second primaries in patients who were getting olaparib. And that was, for me, a very interesting concept as well, because it does suggest that we perhaps need to be taking olaparib into the prevention strategy, something that is currently ongoing. When you look at the adverse events, there were higher adverse events in patients who were taking olaparib, 91.7% versus 83.3%, but most of these adverse events were tolerable. They were not very advanced adverse events. There was MDS and AML was about 0.2%, with 1% of patients actually getting pneumonitis. Now, when these results were presented at ASCO last year, literally on the same day, we saw the New England Journal of Medicine paper, as well as the ASCO write-up that recommended that this drug be incorporated immediately into the treatment paradigm of patients with a BRCA1 or a BRCA2 mutation. Now, that was not the only important piece of data that came out for patients with HER2-negative disease. The other question that we asked ourselves was, among patients with high-risk triple-negative breast cancer, could we further improve prognostic outcome, perhaps by using platinum-based therapy and perhaps by incorporating the use of immunotherapy? Now, we know from the Keynote 522 trial, this was presented at ESMO in 2019, and we did see the ESMO virtual plenary update this year as well. The Keynote 522, as you remember, this was a group of patients with triple-negative breast cancer in the neoadjuvant setting who were randomized to receive either pembrolizumab plus chemotherapy or chemotherapy alone, and you can see that it significantly improved the pathological complete response rate from 51.2% to 64.8%. And in terms of the event-free survival, you can see an absolute benefit of 7.7% with a 37% reduction in the risk of recurrence of disease. And if you split that event-free survival by PCR status, you can see that in patients who did not achieve a pathological complete response, you can see a 10.6% benefit in terms of adding that pembrolizumab in the neoadjuvant setting. Now, what about patients with high-risk ER-positive, HER2-negative breast cancer? Could we further improve prognostic outcome, perhaps by extending adjuvant endocrine therapy, perhaps by incorporating adjuvant ovarian function suppression amongst patients who are premenopausal, and perhaps by incorporating adjuvant CDK4/6 inhibitor? You've all seen this data. We know the results from the SOFT trial that adding ovarian function suppression significantly improves disease-free survival and overall survival compared to using tamoxifen alone in patients who are premenopausal. And we've also seen from the combined analysis of the SOFT and the TEXT that using an aromatase inhibitor improves disease-free survival better than tamoxifen when combined with ovarian function suppression in those premenopausal women. We've also seen 3 adjuvant CDK4/6 inhibitor trials in combination with endocrine therapy. 2 of them were negative studies, the PALLAS and the Penelope-B, that used palbociclib. But in terms of using abemaciclib in the Monarch-E trial, we saw that when you randomize patients in the adjuvant setting to either endocrine therapy alone or endocrine therapy plus abemaciclib, you can see a 3-year invasive disease-free survival benefit of about 5.4%. And we certainly have seen that this IDFS benefit was maintained. We saw this published by Nadia Herbach late last year in the Annals of Oncology, and you can see that there's a 30.4% reduction in the risk of developing an IDFS event when you in fact used adjuvant abemaciclib, and this is what led to the FDA approval of adjuvant abemaciclib. So going forward, I think the questions we are going to ask ourselves in those patients who have BRCA mutation positive diseases, among patients with TNBC who receive neoadjuvant therapy and have residual disease, what is the optimal adjuvant strategy? Are you going to continue immunotherapy, give capecitabine, or are you going to use adjuvant olaparib? Now, we've certainly seen the results of the CREATE-X study. This was a very old study that was published in 2017 that took patients with residual disease in the TNBC cohort, randomizing them to receive either adjuvant capecitabine or placebo, and you can see a 14% absolute improvement in DFS and an 8.5% absolute improvement in overall survival. And I think CREATE-X did teach us a number of important lessons. Patients with TNBC who have residual disease obviously have a worse prognostic outcome, and that the addition of adjuvant capecitabine improved prognostic outcome. These were for all comers. We didn't know who had a BRCA mutation and who did not have a BRCA mutation, and there was no suggestion that it would not work for patients with BRCA mutation. We then saw some interesting analysis in patients who were enrolled in the FINEX trial. If you remember, the FINEX trial were patients who in the adjuvant setting got, in addition to everything else, they got capecitabine. And the investigators actually went back and looked at analysis where they substratified patients according to their homologous recombination deficiency status in that TNBC cohort. And you can see that in patients with BRCA1-like tumors, there was no significant difference in terms of outcome of therapy or outcome of patients in terms of their prognostic outcomes. So we couldn't really make any conclusions whether capecitabine was actually working better or worse in those patients with a BRCA-associated tumor. Now, when you go back to the Keynote 522 trial, as I mentioned earlier, in those patients who did not achieve a pathological complete response, there was a 10.6% benefit in terms of adding immunotherapy to these patients. There was no information on the use of immunotherapy in the BRCA mutation-specific cohort. Those analyses probably will be coming out later this year or early next year. But I think one of the questions that we ask ourselves is that benefit restricted to using it in the neoadjuvant setting? Do we really need to use it in the adjuvant setting when someone has not achieved a pathological complete response? And a question that is often debated. So in the BRCA mutation cohort, could we perhaps do better in those patients with residual disease with TNBC? Now, going back to the Olympia trial, you can see in patients who had received either neoadjuvant chemotherapy or adjuvant chemotherapy and had triple-negative breast cancer, olaparib worked in both cohorts of patients. And as I mentioned earlier this year at the ESMO virtual plenary session, we did see the overall survival benefit results. We saw that when you added olaparib in the adjuvant setting to patients with high-risk triple-negative or hormone receptor-positive disease. Now remember, there was only 18% of patients who had hormone receptor-positive disease. When you look at the overall survival, there is a significant benefit, 3.8% benefit at 3 years and a 3.4% benefit at 4 years in terms of overall survival, with approximately a 40% reduction in the risk of death from disease. You can see a hazard ratio of 0.68. Now, would adjuvant olaparib in fact work post-prior platinum use? And I think this is an important question that we ask ourselves. because most of our patients now in the neoadjuvant setting, whether they're getting immunotherapy or not, we're going to use neoadjuvant platinum because we know that these patients in the brightness trial actually had an improvement in event-free survival. So in these patients who have residual disease, that means they didn't do so well with platinum, is olaparib in fact going to work in the adjuvant setting? Well, when you go to the subgroup analysis, you can see that patients who had either prior platinum, a small cohort of patients, or those that did not, the point estimates are both in the right direction, suggesting that olaparib is probably going to work. And when you combine all the data of CREATE-X, KEYNOTE-522, and Olympia, you can see that in terms of the 3-year event-free survival, it appears to be higher in the Olympia group of patients compared to CREATE-X and the KEYNOTE-522, but with the caveat that I obviously don't know the groups of patients within those 2 trials that actually had a BRCA mutation. So the question then comes, in the presence of a BRCA mutation and residual disease in your triple-negative cohort, what is the best strategy? Is it adjuvant olaparib, adjuvant capecitabine, pembrolizumab, or perhaps a combination of pembro plus olaparib? So this is a case of a 39-year-old lady. She has right breast cancer. She presents with triple-negative breast cancer, clinical T3N1M0. She has a BRCA1 mutation, gets pre-op platinum-based chemotherapy with pembro as per KEYNOTE-522, has residual disease, 1 out of 10 lymph nodes. Would you continue pembrolizumab? There is a suggestion that it does improve prognostic outcome. Would you give capecitabine as per CREATE-X? Would you give olaparib as per Olympia, or would you consider a combination? So what do the experts say? So I did conduct a roundtable discussion, which we're writing up currently late last year, and we actually asked the experts across Asia, Europe, and North America, and we asked the question, in your opinion, what is the optimal adjuvant strategy in a patient with early stage TNBC who receives neoadjuvant chemotherapy and immunotherapy and does not achieve a pathological complete response and has a BRCA mutation? You can see that the overwhelming consensus was adjuvant olaparib, although there was a group of people that actually said the combination might be something you would consider. So this is what we did. We actually gave olaparib to this patient. Going to the next question, among patients with high-risk TNBC who receive neoadjuvant therapy and achieves a pathological complete response, so there is no residual disease here, but achieves a pathological complete response, would you not give adjuvant a PARP inhibitor? And a question that we tend to ask ourselves in the clinic, because we know that not all pathological complete remissions are in fact created equal. And this was a very nice study that was actually published last year that took patients with stage 3 anatomical stage 3B triple-negative breast cancer, and these patients had been given preoperative chemotherapy, and you can see that they all had achieved a pathological complete response. 5-year DFS was 86%. But when you split them according to their baseline CPS-EG scores, although they all had PCR, but if you split them according to their baseline CPS-EG score, you can see that those patients with a more advanced disease at presentation had a worse prognostic outcome. So again, not all patients who have a PCR will do the same. So again, we asked our experts, would you consider adjuvant olaparib in a patient with a clinical T4N3M0 who achieves a pathological complete response and has a BRCA mutation? The majority did say yes, but you had a significant proportion of KOLs that said no. So again, a very controversial area, but we know in the NCCN guidelines, it's firmly there, adjuvant olaparib for 1 year in those patients with a germline BRCA1, BRCA2 mutation in the triple-negative breast cancer setting. So this is a potential algorithm that we've come up with that is actually under publication. Patients with a stage 2 to 3 TNBC should be considered for neoadjuvant chemotherapy. If you use an IO platinum-based chemotherapy and they've undergone a pathological complete response, we do continue adjuvant IO. And if they've got very, very high risk baseline disease, we do in our MDT consider thinking about using adjuvant olaparib, although there is no data for that as of now. But if they have residual disease and they're BRCA1 positive, adjuvant olaparib is the standard of care. However, we do sometimes consider giving a combination based on consensus opinion. It's a very similar algorithm in those patients who have not received IO therapy. Now, what about patients with high-risk hormone receptor positive early breast cancer? What is the ideal adjuvant therapy in this cohort of patients? Well, when you go back to the Olympia trial, you can see that in those patients who had hormone receptor positive, HER2 negative disease, again, it was only 18% of the cohort. That's why you see the confidence intervals are actually quite wide. But the point estimate is in fact in the right direction, suggesting that olaparib is also beneficial in this group of patients. So is endocrine therapy in fact enough in this group of high-risk hormone receptor positive HER2 negative breast cancer? Again, when you looked at the OS benefit that was presented earlier this year in the ESMO virtual plenary session, you can see that both TNBC patients as well as hormone receptor positive patients were in fact benefiting from the use of adjuvant olaparib. Now, one of the questions that's come up is from our data that's actually come up in the metastatic setting, and that is in patients who have a germline BRCA1, BRCA2, if you were to give them chemotherapy, and this is a metastatic setting, and this data comes from the ESME database, if you were to give them endocrine therapy alone, they actually do a lot worse compared to patients who have BRCA wild-type disease, both in terms of progression-free survival as well as overall survival. And this results may reflect differences in the oncogenic processes and driver landscape involved in luminal BRCA-associated metastatic breast cancer. Now, we also know that in the metastatic setting, there's a lot of data accumulating that when you give a CDK4/6 inhibitor plus endocrine therapy in patients with germline BRCA mutation status, they actually have a poorer prognostic outcome compared to those patients who have BRCA wild-type disease, really questioning the use of CDK4/6 inhibitors in this group of patients. Now, why do I say this? Because in our high-risk group of hormone receptor positive early stage breast cancer, we ask ourselves, what is the best strategy? Should we be using adjuvant abemaciclib, or should we be using adjuvant olaparib as per the Olympia trial? Or perhaps, should we be considering sequencing our patients? So let me give you a case example. This is a premenopausal 42-year-old lady, again a right breast cancer, ER/PR positive, HER2 negative with a clinical T2 and 1 disease, gets pre-op chemotherapy and has a PT1 and 2 disease. 7 out of 15 lymph nodes are positive. Would you give ovarian function suppression plus endocrine therapy or endocrine therapy alone? I certainly think she needs ovarian function suppression plus endocrine therapy, but she does need something additional. Would you consider adjuvant CDK4/6 inhibitor, or would you consider adjuvant olaparib? At least in my opinion, I think in my increasing order of preference would be abema followed by followed by olaparib, or olaparib followed by abema, but my preference has always been olaparib alone plus endocrine therapy plus ovarian function suppression. So this is the algorithm that we follow in our clinic for those high-risk group of patients with hormone receptor positive, HER2 negative disease. If they're age less than 35, we give aromatase inhibitor. If they're premenopausal at the end of 5 years, we continue with tamoxifen. In our patients who are BRCA mutation positive, adjuvant olaparib if they've got more than 4 lymph nodes that are positive or have other high-risk features that was included in the Olympia trial. And you can see that in the NCCN guidelines, they have actually incorporated that in patients with hormone receptor positive, HER2 negative disease, again, you should consider adjuvant olaparib in combination with adjuvant endocrine therapy. And then lastly, among patients with high-risk HER2 negative disease and a PALB2 mutation, would you consider an adjuvant PARP inhibitor? Again, this is a case of a 39-year-old with a high-risk TNBC disease. She has residual disease post-pre-op therapy, but she has a PALB2 mutation. Would you not consider giving her adjuvant PARP inhibition? Well, we asked our experts, and again, they were equally split. More said actually no, but you had a significant proportion of people that said yes. And we know that in the ESMO guidelines, in patients with metastatic PALB2 mutations, they do actually consider giving a PARP inhibitor. Finally, should we be concerned about the impact on fertility of using a PARP inhibition? Again, the simple answer is yes. We have a lot of accumulating preclinical data that's actually shown that PARP inhibition significantly depletes ovarian reserve of primordial follicles, and this diminished ovarian reserve will lead to infertility and premature menopause. And so fertility preservation should be strongly counseled with your patients who are going to use 1 year of adjuvant PARP. And then it's not going forward. All right, so this is my take-home messages. Adjuvant PARP inhibition among patients with BRCA mutation who have a high risk of HER2-negative disease improves prognostic outcome. We know that incorporating IO in these patients with triple-negative breast cancer high risk actually improves PCR and event-free survival. We have data from the Monarch-E trial that shows that adjuvant CDK4/6 inhibitors also improves prognostic outcome in high-risk hormone receptor-positive HER2-negative disease. But going forward, the key will be to integrate all these strategies of adjuvant PARP, adjuvant IO, and adjuvant abemaciclib. And I think in this day and age, it's unacceptable if patients with HER2-negative disease are not tested for a BRCA mutation. In my opinion, all patients with early stage HER2-negative breast cancer should be tested for BRCA mutation. So thank you very much.
Thank you, Shaheenah, so much. So job well done and within time. I think the adjuvant space is getting crowded and we couldn't have a better speaker than Dr. Shaheenah. So Hemant sir, should I ask first? So Dr. Shaheenah, is IDFS a new endpoint for initially Catherine, now Olympiad? So is it going to be a new endpoint for all early breast cancers?
I honestly don't think IDFS is a new endpoint. We've been using it for a number of years, and Catherine is pretty old, but I do think it's a very, very important endpoint. Because looking at overall survival now is going to be difficult because our patients are doing so well in the early stage breast cancer setting, and we need those results earlier. So yes, it's a very important endpoint.
Yes, sir. Please.
Yes, Dr. Han.
So hi, Shaheenah. Welcome back.
Thank you.
You're looking nice and a great talk as usual. I have a sticky question for you, which I think an expert of world standing should be able to field. Are the three PARP inhibitors available? Are they the same, interchangeable, like the aromatase inhibitors in breast cancer, or are they not? And I ask this question for obvious reasons because we have one generic PARP inhibitor available to us.
So in my humble opinion, there is only one trial with one PARP inhibitor that has shown benefit in early stage breast cancer. And contrary to what you saw with the aromatase inhibitor, exemestane, anastrozole, and Femara, that's letrozole, there were clinical trials for all three of them to show that they worked in the early stage and metastatic setting. We don't have that for the other PARP inhibitors as of now. And if you go back to the metastatic setting, we have data for talazoparib, we have data for olaparib, but if you look at the other PARP inhibitors that were actually investigated, like niraparib, it was actually a negative study. So as of now, I do not think they're interchangeable. I think in the future, as we are seeing those early stage trials coming out, we may be able to consider that, but for now, if you're going to give your patient the benefit of the data that I've showed you in terms of overall survival, you have to stick to olaparib.
Thank you. Fair enough.
Dr.
So
Shaheenah.
Dr. Shaheenah, so a triple negative high risk, so BRCA positive. So Createx versus Olympiad, you have touched upon, and in a HR positive, so Monarch-E versus Olympiad. So how do you select in the clinic? So, or we are going to see a trial of a capecitabine alone versus capecitabine and then olaparib, or an IO, so something like 3 or 4 arms?
So no, I don't think we're going to see those trials because remember the number of patients with a BRCA mutation is also small. Plus, I don't think you'll be able to combine capecitabine with olaparib. I think the toxicities are going to be high in my humble opinion. I think the data is very clear in terms of event-free survival and now overall survival benefit. In a triple neg, capecitabine versus olaparib is the winner. The question is, should we be combining olaparib with immunotherapy? That is something that we need to think about, and I have done it for patients outside the realm of data, but you can see that there's a lot of consensus opinion coming out that you can actually consider it. In hormone receptor positive, you cannot combine olaparib with abemaciclib. Again, the toxicities would be too high. But I would certainly consider sequencing, although there is no data. The reason being, patients with hormone receptor positive disease tend to also recur late. So I think 1 year of olaparib followed by abemaciclib is something I would consider, again without data
But
being
will be
present.
combining hormones with olaparib?
Absolutely yes, because that's the way the Olympia study was. They combined olaparib with endocrine therapy.
But we are not sure what is going to happen after 5 years. So if given a 3% chance or a 5% chance of an MDS and AML in these patients who are a potentially curable disease. So we have not seen,
No, but olaparib you're only giving 1 year. So you give 1 year, but you continue the endocrine
So
therapy.
at
post
1 year
that.
also the damage is there, no? So
Yes,
and the damage can be
absolutely.
permanent.
Absolutely, but if you saw the incidence of MDS, it was actually quite low, it wasn't high. You can get MDS also with chemotherapy, and I think the incidences are actually quite similar.
No, but you are not giving chemotherapy post-surgery, so and high risk.
No, most of those patients are high-risk patients. Most of them got chemotherapy. Chemotherapy in addition to adjuvant olaparib in the Olympia trial.
So yeah, so the damages are both sides now.
Yes, exactly.
Dr.
Yes,
Shaheenah,
Amish, please.
Hi.
Yes, Rajiv.
Dr. Shaheenah, you mentioned categorically that all the triple negatives that we are giving the pembrolizumab trial, all of them have been receiving platinum. That is not yet the standard of care what we are following. We are not giving AC followed by paclitaxel carboplatin. So is that the standard of care in your practice for all triple negatives?
So if it's not standard of care, please go back on Monday and make it standard of care, because
I
according to the brightness, you have now 5 trials that have actually looked at the use of platinum in a randomized setting. I've been using platinums for the last 5 to 7 years in the neoadjuvant setting. You have a lot of data, and brightness sort of confirmed last year at ESMO that it is, when you give it, it improves the pathological complete response and it improves event-free survival in these patients as well. If your patient cannot afford pembro, throw it out the window, but give them platinum, because that's what's going to help them in a very cheap manner. So yes, for me, my platinum is standard of care in the neoadjuvant, not in the adjuvant setting.
It will be very interesting to know what's the of the house also. Are we using platinum on a regular basis for all triple negative? It definitely makes the proof of concept seems very sensible. We've had a lot of discussions on this in the past, but somehow whether it has become the SOC for all of us, I'd be very interested to know about that.
You know, it's actually a very interesting question you've brought up. NCCN till date has not agreed that it is standard of care. But if you're going to give all your patients pembrolizumab, you can only give it as per Keynote 522. And Keynote 522 had a platinum backbone. So for me, I think pembrolizumab, very expensive drug, but we're not using a very cheap drug that can actually improve pathological complete response rate. So.
Yeah, Shaheenah, just to thanks you made the flight this time.
So yes, and I got through immigration as well.
Yeah, right. We missed you for our meeting. And Shaheenah, like you, last 5 years, we in the medical college is using platinum for all triple negative cancers. And I think I presented the data in Dubai for one of your conference, which we got the best paper award.
Yes.
And that's our standard of care, because in a country like India, we can't think of olaparib. When I'm in the medical college, I don't think of any of these. So platinum is now standard of care in all our patients for the last 5 years. And we have excellent results. We have already presented this.
Parikh sir just told me to ask very quick question, but I cannot stop asking you, do you practice before presentations? Because the flow of your presentation is so good. My question to you is, you gave a slide, and we all have been using that slide, where CreateX, Olympia, Monarchy, the EFS at 3 years. But if you see, like, I'm very much interested that the control arm of Olympia was better than the experimental arm of CreateX and Keynote 522. So it is very difficult for me to compare the cross trial. And second thing is, Keynote 522, non-PAT-CR had 10.2%, which is not seen till now, in our practice.
Yes.
So to give up pembro and to add olaparib in these patients, non-PAT-CR, is very difficult proposition for me. And you said you would give olaparib rather than give pembrolizumab.
So my preference is that somehow I have to give them olaparib. honestly, I try to combine olaparib and pembro, and I have a number of patients. It's just that the cost factor is too high. When you add pembro and when you add olaparib. Now that 10.6%, so my argument would be there if you had one or the other to choose. Now if you could do both, well and good. But if you had one or the other to choose, my argument would be choose olaparib. Why? Because you've given your neoadjuvant pembrolizumab, and perhaps that effect that you're seeing in terms of event-free survival is because of the neoadjuvant, not because of the adjuvant, especially since we have data from Japernuvo which shows that when you only give neoadjuvant immunotherapy with durvalumab, you're getting the same prognostic outcome, if not better, than the Keynote 522. So the whole issue of whether we need to give 1 year of pembro is still debatable. If you can, and cost is not an issue, I'd combine the two, quite honestly. But if cost is an issue, I think olaparib needs to be given rather than pembro because the patient's already been exposed and hasn't achieved a PCR.
Excellent talk, ma'am. Do you use...
I can't.
Ma'am, do you use olaparib in the non-Olympiad cohort situations, like in a recurrent situation, those patients who have not had a residual disease, but are recurrent and have not had the chance of, taking olaparib in the first setting? So, do you give olaparib in those situations?
I actually have a number of patients in that current situation where I've given them olaparib, and I have 2 patients right now, triple neg, BRCA mutation positive, very small tumor initially, didn't really fit the criteria for Olympia, gave them, they had surgery, adjuvant chemo, and unfortunately had a local recurrence, had a mastectomy, very similar, these 2 patients. At that point, I actually gave them immuno plus chemo, they achieved a PCR, and now they're on immuno plus olaparib. So, yeah, my simple answer is yes, and we will never have the data to tell us one way or the other.
Apologies, ma'am, we're running short of
Yes,
time.
no, I'm done. Thank you.
Thank you, ma'am. Thank you, Kancham sir. Thank you, ma'am. Thank you, sir. We'll now move on to the oration, which is in the memory of Miss Geeta Ramesh Chandra Gandhi. It gives me great pleasure to introduce our esteemed chairpersons, Dr. Paresh Parekh, Senior Medical Oncologist from Mumbai, and Dr. Hemant Malhotra, Senior Medical Oncologist from Jaipur. Thank you.
Already on WhatsApp groups, we've received so many congratulatory notes and thanking Vijay Patil. So instead of wasting time, may I please invite Vijay to start the oration. He is Professor of Medical Oncology at Tata Memorial Hospital, and we've actually seen him grow from strength to strength right before our eyes. So it's a real pleasure to eagerly await your oration, Vijay.
Thank you, organizers, for the opportunity. And when I was given this topic, I decided what would I be speaking about. Then I decided that I would speak on Indian advances in head and neck and CNS tumors which have happened over the years. Now, I think that in any profession, it is your mentor who guides you. And in this situation, my mentor was Dr. Kumar Prabhash sir. I was his first thesis student, and from there, we had this journey of doing research together, and many questions which we answered were valid in Indian context. Along with that, we had a great lady standing behind us, and as we say that the success belongs to the lady, and Dr. Vanita was always there to guide us. Along with that, we had Dr. Amit Joshi sir, who was also there as a part of the team and used to make us calm whenever things didn't go according to the practice. Three stories I have chosen for today's oration. The first story is of borderline resectable head and neck cancers. The second will be the development and integration of metronomic chemotherapy as a standard of care. And the third would be development of CNS medical oncology in Tata Memorial Hospital. And let me start with borderline resectable head and neck cancer. This were the type of cancers we used to see in head and neck cancer OPDs daily, day in and day out. We used to give neoadjuvant chemotherapy to these patients. However, whenever you talk on forum, this was heavily debated, okay, that you can't give neoadjuvant chemotherapy, you need to do surgery in these patients. And that was the time we decided, no, if we are going to do this, this needs to be done more systematically. And at that time, we decided we'll start making criteria for calling what is borderline resectable. And thus evolved, not criteria were given before that, but Alderstein and Dr. Pradhan, but they were very subjective criteria. And we, after that, developed the objective criteria for calling what we would call as a borderline resectable head and neck cancer. A buccal mucosa cancer, which is going about having edema about the zygoma, or a trunk malignancy, which will have growth very near to the vallecula so that your hyoid needs to get resected. The issue was when you had such extensive tumor, either you can't have a margin negative resection or you cannot have functional resections in these patients. And many of the surgeons would actually operate on such kind of patients. After that, we published a flow of borderline resectable head and neck cancer. All of these cancers used to get discussed in multidisciplinary clinic. We used to give 2 cycles of neoadjuvant chemotherapy. After 2 cycles, we would take them back to the multidisciplinary clinic, decide based on the response and PS whether we would continue with a radical intent or we go with palliative intent. What did we achieve with this? What we achieved was those patients who underwent surgical treatment, they had a 2-year progression, a 2-year overall survival of 47%. And let's keep that figure in mind, a 2-year overall survival of 47%. Better, those who got operated and if they received adjuvant therapy further, this survival was more better in this group of patients. And let me put this in perspective for many. Why is this 2-year survival of 47 or 50% so important? And this is the data of VOCAT study, a 900 patient study who were upfront operable, who had T3, T4 or N2, N3 tumors. Look at the median survivals. The median survivals here are 18 months. And now when you go back and look at the median survivals of a T4B or a heavily node positive who were considered unresectable, after neoadjuvant chemotherapy, when you give this kind of outcomes, these are truly promising. Now a lot of things went again. Ours was a pragmatic group. Not every patient could receive TPF. There were logistic issues in giving TPF. We used to follow this algorithm kind of looking at the logistics about what would be the cost involved, what would be the comorbidities involved, how fit the patient is, and it would be a practical aspect whether you give 3 weekly DCF or you would go for a 2-drug 3 weekly regimen or even a weekly regimen. The question was, are you justified in giving a 2-drug regimen when you had a 3-drug regimen? Most of the time, logistics actually dictated that the 2-drug regimen was given. We did this retrospective analysis in which about 245 patients, Dr. Vanita is the lead author in this, compared whether a 3-drug regimen is as good as 2-drug regimen or not. The answer was clear, the 3-drug regimen was better than the 2-drug regimen. But there were certain questions. Most of the 3-drug regimens were given in a private setup in the patients who had better build-up, better nutrition. Most of the 2 drugs given were given in a general OPD setup. The issue was we could prove this in a prospective study. This got overshadowed by the low-dose immunotherapy and the docetaxel presentation. This was presented this ASCO by my colleague Dr. Ajay Singh. This was a study of 496 patients, the first study of borderline resectable head and neck cancer. Half of them got randomized to DC, half of them got randomized to DCF. And these are the mature results, and this manuscript is in preparation. And you could see in these long-term results, it's clear that there is an advantage of giving 3-drug regimen over a 2-drug regimen in a randomized comparison. So DCF still holds betterment with respect to progression-free survival and with respect to overall survival. Did it come at the cost of toxicity? Yes, it did come at the cost of toxicity, with grade 3 and 4 adverse events happening in nearly 70% of patients with DCF, as opposed to nearly 40 to 50% of patients in the DC regimen. Most of the work which I have done and which I will be showing was not done by me alone. A dedicated group of residents used to work with me. In our unit, it's a policy that our residents are involved when the trial is running. They need to know about what the protocol is, how the regimens have to be administered, so that when they go in the society, if this becomes the standard of care, they could be easily integrate this. These are the dedicated group of residents who worked on this project. And Ajay, the large picture, he actually presented these results at ASCO this year. There was one problem we used to face, and many of you who are in this hall have worked in Tata, that a lot of patients of our 5FU used to have diarrhea. And this was our discussion with one of our students, Dr. Saurabh Zanwar, who is now in Mayo Clinic, that why these patients are developing diarrhea. So what we did is, those patients in whom there was severe mucositis or diarrhea, we actually started sending the DYPD mutations. What we saw was, most of them, nearly out of this 11 of them actually had DYPD mutation. We had a problem. DYPD mutation at that time, we used to get it done from outside, and it used to cost some 10 to 13,000 of rupees, depending on the lab which was. And it was not feasible for us to do DYPD in all patients with this cost of DYPD. And then stepped in Dr. Anuradha Chaugule madam, she developed a protocol for doing DYPD in our lab itself, and it cost only 3,000 rupees to the patients. We subsequently did it for 118 consecutive head and neck cancer patients, and we did show that around 24% of our patients had this DYPD mutation, and largely this was in exon 13, where A gets replaced with a guanine, and that's the picture of Dr. Anuradha. We didn't stop it here. We continued. We continued to take this project for 1,000 plus patients, and after 1,000 plus patients also, it was seen that nearly 28% of our patients had DYPD mutation. This database now is about 5,000 patients, and this soon will get published. Now, another thing we realized is that giving TPF was a tough job. So we wanted to know how can we deliver TPF safely. At that, we actually saw that when we give TPF in India, and this is in comparison with all international studies, we get a lot more amount of febrile neutropenia, a lot more of hyponatremia, which was not reported, a lot more about mucositis. If Dr. Vamshi and Dr. Bharat, at their time TPF started with a year, they could have told us that patients used to land up in casualty with seizures because of hyponatremia. And then we had to decide, okay, how do we deliver this safely? And this work was done by this pharmacy student of ours, Nilambari Savadekar. What we did was, for 55 patients, daily toxicity monitoring was done. We actually did counts daily, we actually did electrolytes daily, and we wanted to see which was the day when the ANC fault, which was the day when the potassium would fall, which was the day when sodium was fall. The idea was, can we predict that all these toxicities would happen in some defined time interval? And if you admit the patient in for that defined time interval, you could actually manage these toxicities indoors, and you could say that, okay, if the patient is admitted for 10 days, 90% of these toxicities would happen in that time, and the patient can be safely discharged after that. And we actually saw that if you look carefully, most of the toxicities would happen within 10 to 12 days. And if you admit the patient for 10 to 12 days and manage this toxicity well. See, management of toxicity is not a problem. As medical oncologists, we manage toxicity of AML, we manage toxicity of escalated BCOP. The problem was we used to discharge the patient, and when the patient used to come, and they used to come late, and that was actually the problem. What this study actually showed, that if you keep the patient admitted for 10 to 12 days, it's very safe to deliver the TPF. I could proudly tell that our mortality with TPF in Tata Memorial Hospital is 1.5%. If you compare that with other hospitals in US, in real world setting, you could see in this paper it is 14.3%. So this is not a regimen which should be taken lightly and needs to be given under proper care. Now, TPF requires logistics, requires PICC, requires you to deliver a lot amount of efforts in that. Can we have an alternative regimen? And here is Dr. Lakhan Kashyap, and this work was actually started at the time of COVID. Many of our beds actually went for COVID. At that time we came up with this. We have a metronomic chemotherapy. We had weekly paclitaxel carboplatin. Why not make a metronomic schedule of weekly paclicarbo and triple metronom? So a 5-drug regimen for giving chemotherapy. And to our surprise, when we gave that to our first 14 patients, you could see in the water plot that most of the patients, there was a decrease in the size of the tumor, which could see, and you could see that in the scans and the photo of the patient. This actually was published by Lakhan in the eCancer, and we could actually good overall survival in these patients, and this at a very, what I would say, acceptable toxicity profile. And actually, I would need to thank Dr. Gunjesh, who is sitting in the audience. He actually got posted in Tata Muzaffarpur at that time, and this was used in Tata Muzaffarpur as the standard regimen for delivering neoadjuvant chemotherapy, and these results were replicated by him and was presented by him in the ASCO of 2022. We actually in Tata kept going up, and we now have a database of 72, and this was again presented by one of our students, and this was by, actually work was done by Shruti and Zoya of data collection for this project, in which we saw that this regimen could be delivered safely. It was efficacious, and the results could get recapitulated in 72 patients. At present, this database stands at around 130 patients. The question is, can it replace the standard TPF regimen? And that is the question of our next phase 3 study, in which we are going to compare TPF as the standard arm versus this metronomic regimen of paclitaxel carboplatin with 3-deoxyribonucleic, and this would be the thesis topic of my current student, Dr. Rumeli Roy. Now, let's talk about response. You gave chemotherapy. The problem is, you would have seen this multiple times, there's a good shrinkage of the tumor which is seen visually. Unfortunately, when you see it at radiology, the radiological response assessment comes at stable disease, or it doesn't come as appreciable as it's seen with what is seen in clinical practice. And this is what we actually realize. Our surgeons used to say, oh, there is a good photographic decrease, but radiologically it's not that great. Should we operate or not operate? So hence, to answer this question, we actually took 23 patients who had developed near pathological CR. We went back and saw what did the radiologist reported. We also went back and saw what did the patient's perception was that. And this work was done, and I was helped in this work by Dr. Vamshi and Dr. Bharat actually. And the radiological assessments were done by Dr. Sashikant Zuvekar. He was the backbone of all our NACT studies, in which he used to do response assessment for all of us. And this is what you could see, that even in patients who had pathological near CR, you could see that not all patients had a very good partial response. Not all patients had a CR. In some patients, actually, there was suggested that there was an increase in the size of the tumor, and there was very limited correlation between what was the pathological response and the radiological response. But if you ask the patient, did your tumor decrease? And that actually was very in concordance with that, they felt that 80 to 90% that the tumor had decreased. And that's the reason why we decided that henceforth after this study, we would be taking clinical photographs of all these patients before the NACT and after the NACT. And this is just an example how a good clearance can be there on clinical photographs itself, but the radiology may not be in line. After this, our discussion with our group of surgeons, if there is a clinical response, they are more than happy to operate these patients because they also do well. But the question is, why does this happen with RECIST, where you would have good subjective response, but not a good objective response? That is because this is the way RECIST gets calculated. If your tumor is a cylinder or a sphere, a decrease in dimension is good. But if your tumor is irregular, as is the case in head and neck cancer, you don't actually go back and look at the same dimension. You look at the longest dimension, which may or may not be the same dimension. And sometimes there is not a centripetal shrinkage of the tumor, there is a differential shrinkage of the tumor, because of which this was seen, and this was also seen in this study, in which we showed that no, you need to have not only radiological response assessment, but clinical response assessment, and you need to take into mind what the patient is saying. So now you are given neoadjuvant chemotherapy, you have seen that there is a response, let's do surgery for these patients. And the question is whether when you do surgery in these patients, whether you can achieve margin negative resections, because that was the question with which we started with. If this patient responds, at least at Tata, the margin positive status is less than 1%, and the closed margin status is only 2.96%. Now the question is, how would this get compared if you looked at T4A or T4B, which get operated upfront and which were considered resectable? And this work was done by Colonel Sahu. Unfortunately, I didn't have his photo. And this is a comparison of 400 patients, 215 who underwent upfront surgery, 215 who underwent neoadjuvant chemo and then surgery. You could see that for all parameters, closed margins, positive margins, there was no much difference. In fact, the results were more in favor of giving neoadjuvant chemotherapy followed by surgery. Just to make the point that when you operate after neoadjuvant chemotherapy, you can achieve negative margins, you can achieve the poor prognostic factors actually go down. What about the complications which happen after neoadjuvant chemotherapy surgery was done? This work was done by me in work with Dr. Shantam Chakwi at Malabar Cancer Center, in which we actually looked at what were the post-operative complication rates in patients who have undergone upfront surgery versus neoadjuvant followed by surgery. There is a minimal increase in certain local regional complications which is seen in this situation. Okay, neoadjuvant chemo given, response is there, you underwent surgery. The question is, what do you select? Do you give radiation? Do you give chemo radiation? Or if you want to give chemo radiation, what do you select? The issue is you cannot operate to the pre-NACT margins. If you could have operated to the pre-NACT margins, you could have operated the patient upfront. You normally operate according to the post-NACT margins. So you are not very sure whether the margins which are there, which are looking sterilized at pathology, are actually, were they positive at that time. So at Tata, our policy is to give CTRT in these patients. Most of the time we select cisplatin in such situation, but we need to be careful about selection of cisplatin. As the cumulative dose of cisplatin increases, you would have given 150 to 225 milligram per meter square of cisplatin in the neoadjuvant setting. When you give more amount of cisplatin in the concurrent setting, you could see this in this study, that there is a steady rise in creatinine which would happen in this patient, and they may develop metabolic syndromes. There's an interesting question, and this was actually presented in ASCO by Sudeep and Somnath, where let's take a situation, patient gets operated. One situation, there is a pathological CR in the node and the tumor. Second situation, pathological CR either in the node or in the tumor. And third, there is no pathological CR. Can you get away without doing CTRT in these patients who have a pathological CR in the group 1? First thing what we found, those who developed pathological CR, they had a great outcomes. Second, interestingly, we saw that even if the patient had a pathological CR in the tumor and in the node, they did benefited with the addition of concurrent chemotherapy along with radiation, and this was seen, and this was a pretty large study of around 100 plus patients with around 50 patients that will be in each group. We are going to give so much amount of chemo to these patients. In neoadjuvant setting, we are going to give chemo during the CTRT. You need to be bothered about the metabolic syndromes which would develop in these patients in their follow-ups, and that is one of the things which I would say, that if the patient has received neoadjuvant chemotherapy, then has received CTRT, we need to look at the metabolic syndromes, and quite a few of these patients actually develop impaired glucose tolerance over a period of time. Now, what has been the impact of this development? We have actually published, I have shown you a snapshot of few studies, around 35 to 40 studies in the space of borderline resectable head and neck cancers. Did this made an impact? Only one randomized study, actually, rest of the data is retrospective but of good quality. We found that, and we actually did that there was a good adoption of this technique in South India, North Central India, Sub-Himalayan region, Western India, and even in Eastern India, and these are the references. Actually, we were surprised that this actually came as a paradigm shift in few of the articles. And this was a very pleasant surprise to me. Dr. Vamakon, those who follow head and neck oncology would know he's the first author of Extreme Study and a renowned authority. A recent textbook in Springer, he actually has devoted a chapter on this, on borderline resectable and technically unresected head and neck cancer. He argues that you need to be giving neoadjuvant chemotherapy and then following up this patient in accordance with the response. Again, a pleasant surprise when the resource constraint guidelines from the ASCO was written by Fagan. It actually did show, they actually had put it in center that there is something called technically unresectable, and induction chemotherapy giving in this setting is one of the valid option in this setting. This was about borderline head and neck cancers. Do we have some high impact work which has come from Tata in the NACT setting? Absolutely yes. Mandibular preservation trial. Up till now, organ preservation in head and neck cancer meant preservation of the larynx. We never talked about preservation of mandible, which was important for cosmesis purpose. It's important for swallowing. It's important for mastication in this setting. And this is one of the first studies, taking a clue from Lisa Lisitro's studies, where you operate on the post-NACT volumes, you could spare mandibles. And this was an interesting study. We completed a study actually in 2014 and 15, and now for a long period of time we didn't publish it because we were waiting for the data to get matured. And Dr. Shiva and me actually had the privilege of doing the data entry and writing the first draft of the study. And we saw that over 8 years there is no difference whether you operate upfront or you give neoadjuvant chemotherapy and spare their mandibles. Question is how many mandibles we could spare? It is 66% of the mandibles got spared in this setting. And there is good data now which goes up to 8 years where you could see that the curves are just intermingling and there is no, no bad impact of neoadjuvant and doing mandibular sparing. Another thing which actually gets quoted in NCCN a lot for giving cisplatin etoposide in Kaddish, C and D stage for vestigial neuroblastoma. This was a small study, but we had the initial results coming for 2 years. Now the results have gone for up to 6 years. And Dr. Vibhor and Dr. Saurabh had worked hard on this database to maintain this database. Another few interesting studies which came, one was for giving induction chemotherapy in maxillary sinus. Induction chemotherapy in patients who are likely to have stridor. So when you talk about organ preservation in larynx, if the patient suddenly has a stridor, you need to do tracheostomy. You do a tracheostomy and then after that, preserving that organ is difficult. We actually explored whether giving induction chemotherapy, it was a very vigorous protocol. Of course, can it be delivered? And yes, in 70% of the patients we could avoid tracheostomy and also preserve their mandible in long term. This work largely was done by Dr. Bhavesh and Dr. Bharat Chauhan. With that, I'll stop on the story of neoadjuvant chemotherapy. I'll take on to another favorite topic of mine, head and neck cancer, palliative therapy. The issue was, this is one of the commonest tumors in India. If you see at Globocon, because oral cancer, lip, larynx, hypopharynx get divided differentially, it doesn't come up. But if you collate that, head and neck is one of the commonest tumors in India. Unfortunately, 85 to 90% will be coming in locally advanced stage, and most of them relapse. Accessibility and affordability is an issue. Unfortunately, this disease is seen in patients who have come from low socioeconomic strata, and they even don't want to waste 1 day of their life to come to the hospital because that means they lose their daily wages. And this exactly was the situation when we started working on this topic. We actually saw whether how many of them could have received immunotherapy, and this data was presented by Dr. Ravi, and this initial work actually was started by Dr. George Abraham, and we saw that very few amount of our patients could actually afford immunotherapy. So what would we do? Before we started that, we actually wanted to know what is the expectation of the patients. What does the patient wants when he wants to undergo palliative chemotherapy? Does the patient want to live longer? Does he want to have symptom control, or he wants to have both? Whether he is okay to lose his life for some amount of most time which we wanted to go at home. And a lot of people, Chandrakanth, Ashay, Vikas, Anand, Siddharth and Arun were a part of this study. And this is the first study and probably the only study in which patients have been asked after counseling what you actually want from your treatment. Interestingly, 75% of the patients, in spite of the poor prognosis being explained, wanted an increment in lifespan. Obviously, they also wanted symptom control, but that wasn't glaring. We actually thought that many of the patients would opt only for symptom control. Another slide which I have not shown is most of these patients, 90% of these patients wanted 80% or more of their time to be spent at home, which means they don't wanted to visit in the last few days to the hospital. They wanted this. And this is actually goes with the Chris Broth's concept which came in GCO a few months back, that time toxicity, where the time which is spent at hospitals, which is spent at doing investigation, is time away from their loved ones, and that should not be included in progression-free survival. He argues in that way, and that actually is a valid argument. And the whole story of Metronomic actually doesn't start from Tata Hospital. The whole story of Metronomic starts from Derwan, which is a place in coastal, in the Konkan region, and it starts from this person who is a teacher to all of us, Dr. Shripad Banauli. We just followed what Sir told. The original concepts of Metronomic, the development of Metronomic was completely done by Banauli Sir. The time was in 2010 when we used to visit Derwan. We used to see that patients who have been giving celecoxib and methotrexate, they used to do well. We actually wanted to do a randomized study, and this was given by Dr. Kumar to me as my thesis topic. The problem was there was not a single data set for me to do a sample size collection of how much Metronomic used to benefit. So I actually did in this OPD, this first 18 patients, and this was the first ever data of Metronomic which got published, which actually showed us that this is promising. But the data of 18 patients, when I took it to the statistician, he told me this is not compelling enough to do some sample size calculation. So I expanded that data to 64 patients and saw that, yes, it had some merit in testing further. And thus, this was the thesis topic for my DM, which was given to me to do a randomized study of cisplatin single agent versus metronomic chemotherapy. And what we wanted to know is how would metronomic do in front of cisplatin. To our surprise, both the PFS and the overall survival were improved by metronomic chemotherapy. We got really excited with this, and when I joined back as consultant in Tata Memorial Hospital in 2015, we decided this is the time we need to decisively prove whether metronomic works or it doesn't work. And we actually planned a large phase 3 study of comparing this two regimens of metronomic versus cisplatin with the gold standard endpoint of overall survival. Now, there was an improvement in overall survival which was seen in the study. And apart from the extreme regimen and the keynote 048 regimen, this is the only third regimen over last 30 decades which actually has shown that it can improve survival over chemotherapy. It also improved quality of life. But its impact was larger than this. If you could see the side effect rates, it was less than 20%. If you could see the cost, it was actually a minuscule of cost what would be cost by cetuximab or pembrolizumab. Obviously, after this results came, we started giving metronomic right, left, and center. We started giving metronomic even in early failures and platinum refractory, a two-drug metronomic. We failed miserably. The median survival with double metronomic in this situation was only 110 days, and this work was largely done by Dr. Rakesh Pinati. And it was at that time when also, with a phase 2 study, I had visited ASCO, and one of the Scandinavian lady actually bashed me right, left, and center that if you want to develop metronomic chemo, there needs to be a model. How do you say that this is metronomic? How do you know what the dose is metronomic? What is the biomarker for metronomic? How does it act? What is the resistance mechanism? And that actually had a large impact on my mind that, okay, this, what the lady said was true. I was appreciated by most of them, but those negative criticisms were important. At that time, I used to work in Malabar Cancer Center, and I came across this very intelligent statistician. Unfortunately, we couldn't retain him at Malabar, neither we could retain at Tata. He's at Oxford at present, and Dr. Atanu Bhattacharya. I told him this problem, that all phase 1 studies will have increasing the dose to look at maximum tolerable dose. What I want is the dose of metronomics is somewhere between 1/3 to 1/10 of the maximum tolerable dose. How do I get to this dose? We did quite a bit of reading. We contacted Dr. Rakesh Jain and Eddie Pasquier. And what came across was circulating endothelial cells and circulating endothelial progenitor cells could be very good biomarkers for causing the metronomic activity of this. And thus was born the first statistical model to define whether a drug would have a metronomic action. And second, if it has a metronomic action, what is the dose at which it would have the best metronomic action? And that was what we defined as an optimal biological dose. It took us an year and a half to make this model, validate this model, and get this published in a statistical journal, because without a peer review validation, you cannot use a model in clinic. What we did after that was we actually planned the first phase 1 and phase 2 study of joining erlotinib, methotrexate, and celecoxib in platinum refractory and early failure. This was a huge effort. I'll tell you why. This study had a phase 1, and up till now, no one had done pharmacokinetics for this. So I need to thank Dr. Vikram Gota. We did the pharmacokinetic analysis of all patients who were in phase 1, looking at methotrexate and celecoxib levels, how the half-lives differ, how their destruction does happen. The second was we had to measure circulating endothelial cells, and this measurement circulating endothelial cells was done at baseline, at day 8, day 30, and every month. The problem is circulating endothelial cells are very fragile. You need to take the sample processing needs to happen in around 4 to 6 hours. So we had to have a systematic plan how the sample would travel from TMH Parel to Kharghar, where the lab was situated, which itself is 60 kilometers apart, and this processing started within 4 to 6 hours. And there I need to thank the people from the lab. There was a person who used to sample just 5 minutes before the vehicle left. The vehicle, it used to go with all temperature measures been kept. It used to be collected with the time input, whether it can be used or not, and used to be processed at that day, and we would get the results by the evening. And this whole work was done by Dr. Manish, who is here, the builder guy, who now is in Germany and doing his, pursuing his higher studies there. At the same time, there was another question which came was, many of the head and neck cancers cannot swallow. Now, we used to give them crush tablets. Whether whole tablet versus crushed tablet, you would get the same levels in the blood or not was an interesting question, and that was actually answered by Dr. Manjunath. And this was the model which was based on response rates and a decrement in circulating endothelial cells and progeria endothelial cells, which we had used in this to define which would be the best dose of metronomic chemotherapy. We were surprised. We are dealing with platinum refractory head and neck cancers. The response rate is 5% when you use chemotherapy. If you use cetuximab, it is around 5 to 10%. If you use nivolumab, the response rate is 15%. We started seeing responses from the first patient itself, and we got a response rates of nearly 43% of the patient in this setting, and these were quite beautiful responses. You could see that this is the waterfall plot, but there was a problem. What I've shown below is the duration of response. If you look at the duration of response, they were short-lived. People used to have response, but this response used to die within 4 months. We got respectable PFS and OS, which was similar to what was seen with immunotherapy, but we were not happy. We were that, oh, there is a response, but the response never used to last. We needed to have a method to see that the response to triple metronomic chemotherapy needed to last. We did quite a bit of literature search, and the answer which came was immunotherapy would be that would help us to make this response durable. The problem was, if I added to triple metronomic chemotherapy full dose of immunotherapy, this would have, the cost would have got such exceeding that this would have defeated the purpose of development of metronomic. So the challenge was, how could we have a sustainable response but come down on the cost? At that time, this brilliant research came to our help, where we saw that the saturation of PD-L1 receptor used to happen at 0.3 milligram per kg itself, and probably giving further doses may not be required. And hence, we planned this study in which one arm received triple metronomic chemotherapy, which was the standard for Tata Memorial Hospital. The another arm received triple metronomic chemotherapy with IV nivolumab 20 mg. The dose of 20 was selected because for a 60 kg, using 0.3 milligram per kg, a dose of 18 mg was required. And another, there was a logistic issue here. The vial is to come off 40 mg, so we needed to split the vial because the budget also was limited for the study. In fact, the budget for the study was sponsored by one of our patients of lung cancer, or else the study wouldn't have been possible. Did we have some clues? And this data was from Dr. Amit Kumar. I'm not sure whether he's in the audience. In fact, we had given this as compassionate ground in the OPD, and we had seen that, yes, low doses actually did well. Another data, which for reasons beyond my understanding is not getting published, is the PD-L1 expression. This is the 500 patient data, which shows that most of our patients, 89%, have high PD-L1 expression. And taking these clues, we said, no, we would do the study. And to our surprise, the response rates were increased with the addition of nivolumab. The depth of response was increased. It led to an improvement in progression-free survival. It also led to an improvement in overall survival. It also improved the duration of response to 9 to 10 months, which is what we were targeting in this. And importantly, it brought down the cost. The cost came down by 90% when we used this regimen. This work wouldn't have been possible without those dedicated 3 ladies who were standing there. Gunjesh was a part of this work. He knew how fast this recruitment was done, because we were afraid that if we don't have 2 patients at one time to split the vial, we would. And so actually we recruited in 5 to 6 months this study, and he was in the OPD at that time. Dr. Sachin Dumar, I have dedicated a slide. He is central to all studies which I have done in head and neck cancer. And the guy who was holding a baby is Dr. Rahul Ravin. This was the thesis of this student, and he was my first DM student. This was, Dr. Hemant was there when we were discussing about if IO response. This was one of the patients in this study, and you could see that this was progression on DCF. This was such a brilliant response seen in a few months that we actually got our surgeons convinced to operate. The patient's PD-L1 was 80 to 90%. It was a near pathological response. You need more validation of this data. Low dose nivolumab works well with metronomic chemotherapy. Can it work alone? That's a question, and that is a question we are answering in a study called Delhi, that is development of low dose immunotherapy in India. It's a big study of 800 patients. Dr. Kumar, Dr. Sudeep, and Dr. Badwe are joined to the PI of this study, and we are running this study. We are nearly completed 40% of this, and this will give answer. But the pudding is, if these results get replicated across multiple centers. And here I need to thank my friend Dr. Ashay, who developed few friends, and they started having a joint study. And I'm showing you the pictures of the people who are the highest recruiters in the study. 90% of the study is recruited. It is triple metronomic versus physician choice, even has immunotherapy if they can afford. And if everything goes according to plan, I think you would see Rushabh or Sudhi present in this data in ESMO 2023. Other ideas which we had was, why not think about joining paclitaxel with triple metronomic chemotherapy? Fantastic study. This got approved in 2018, and I'm still awaiting funding for this study to start. Thankfully, one of my colleagues, Dr. Akhil Kapoor, has got this approved as standard arms in Varanasi, and we will be starting this study from Varanasi. Quite a bit of time when we used to give pembrolizumab in those affording patients, the question was, do we need to give cisplatin 5FU, or you could give paclitaxel carboplatin? This was the data which was actually done by Mitali, who is an MSc research student, of giving pembrolizumab plus paclitaxel and carboplatin, which we published. It's a small study, but the thing was, this actually gave you confidence that this could be given in head and neck cancer. In this ESMO, we saw a large data coming up. Understand that early palliative care is key. We had data from Tamil in lung, we never had data from India in head and neck cancer specifically. This was the first global study of looking at whether early palliative care helps in head and neck cancers or not. And the two people whose photos I have shown, one is Dr. Pankaj Singhania. He was a student from palliative care. He's now a physician in Manipal. Brilliant work was done by this guy. Another was an observer with me who was now in Mayo Clinic. Her name was Anuja Abhankar, who worked hard on this study. Another thing we saw was a lot of patients used to have distress. If you sent to a psycho-oncologist, there was only one in Tata, and he used to give a date after 4 weeks or 5 weeks. By that time, the patient would go in complete distress. And we decided that if we could remove some time out and do a stratified counseling on these patients, they could, whether this distress could get resolved or not. We actually could resolve distress of around 70% of the patients. This work was done by multiple people. I have shown the photo of Nikhil because up till now I have not got a chance to show the photo of Nikhil. Now, metronomic chemotherapy did wonders for us. The question was, could metronomic do the same wonders when given in adjuvant in a curative setting? We were very aggressive. We launched 4 studies. One was recurrent head and neck cancer, salvage surgery done, not fit for radiation, metronomic versus observation. The second was radical CTRT, CR, observation versus A. That was a 1,000-patient study. This one study, oral cancers, complete treatment has been done, randomization between observation versus OMCT. And one, the famous NACT CT study by Dr. Pai, which has just finished recruitment. Unfortunately, the RMAX study, and I had alluded to in this moderation in head and neck cancer, a lot of work was done by Dilip and Sujay in this study, actually showed negative results with this. In fact, MACE CTRT, this is in review at present, and this was again presented at ASCO this year in the review in a Lancet group of journal, and actually showed similar results that metronomic in adjuvant setting is not doing well. And few of the people who worked on this were Devanshi, Divya, and Nandini a lot. And I need to thank Dr. Sarbani. I'm not showing you the data of CTRT. There's a lot to show in CTRT, but constraint of time, I've decided that the next topic which I'll be speaking on is CNS, because we never have shown our CNS work at any forum. Dr. Sarbani has been, very rarely you get such good colleagues who would help you out in all your studies, recruit them, give dates for radiotherapy. And without her help, we couldn't have done many of the CTRT studies. In 2015, when I joined Tata, I was given a job to develop neuromedical oncology in Tata. And one of the first things I decided was I would replicate the model of head and neck cancer. So there's relapsed glioma, recurrent glioma, let's see what they want. Interestingly, when we saw both, this was different from head and neck cancer. They wanted both. They wanted symptom control also, and they wanted prolongation of life also. And improvement in lifespan was a thing which was wanted by 90% of this patient. Largely work was done on this study by Dr. Vijay Simha. We after that actually did a 600 plus patient analysis of pattern of care of relapsed glioma, and this is in review in a journal at present. It was presented by Nandini in the KSMO conference. Nandini is my colleague who works with me in CNS. What you see here is an interesting thing. If you treat these patients, they do benefit. But whether you treat with radiation, surgery, or chemo, it seems that more or less they are similar. And this was one of the first times this data went down, which you could say confidently in relapsed gliomas, systemic therapy, radiation, or resurgery nearly have the same outcomes. We can't go away without bevacizumab in gliomas. And this was the data, first data which came from India on bevacizumab. A lot of this work was done by Monica Bopanna, which showed that bevacizumab had similar pattern of benefit as is seen in international studies. But the interesting thing was this. This is actually a quittest plot. The area which I have shaded in red is the time which the patient spent with toxicities. You could see that most of the patients on bevacizumab actually have a good quality of life when this data came out. But the question was, we started getting biosimilars, and biosimilars were a lot cheaper. And hence we did this propensity match analysis to see whether, as opposed to innovator, whether you used a biosimilar, whether the outcomes were similar or not. Again, Gunjesh, Hollis, and Anu worked a lot on this project, and we actually did show that yes, they had similar efficacies. The next question was, Dr. Rakesh Jain's hypothesis suggests that giving low doses of bevacizumab may be better than high dose. In fact, high doses of bevacizumab had a negative study in presence of CCNE versus CCNE plus high dose of bev was a negative study. And we always thought that a low dose of bevacizumab actually normalizes the channel. A high dose of bevacizumab actually blocks the channel. So giving a low dose might be beneficial. And this was a hypothesis generating study in which we had given low doses of bevacizumab around 1 milligram per kg, and it actually showed that it seems to be having slightly better outcomes than that of full dose of bevacizumab. Now, we all would agree as medical oncologists, we need prospective studies, and this is a study called Vamana, taking inspiration from the Vaman Lord, he could grow in size, that low dose of bevacizumab actually in body would grow in size and might give us better outcomes. And this is a recruiting study, around 30% of recruitment has been done on this study. But the good thing is that you don't forget CCNU and temozolomide. In selected patients, in residual gliomas, when you give CCNU, you get excellent outcomes. Two students, Dr. Rais Tonse and Dr. Ram Abhinav actually worked hard on this. Selected patient, you can actually do re-challenge of temozolomide also gives good outcomes. What I mean by selected, 2 years or more of DF5 in these patients. But the question was, could you do some repurposing in gliomas because it had a very bad outcomes? Mebendazole came as an answer. Mebendazole had anti-glioma properties. There are 3 versions of mebendazole, A, B, and C, what we could call as polymorph. C is not available in India, but it has the best CNS penetration, around 70% of its penetration. So there was a drug which was out of patent, it was cheap, it had anti-glioma properties, and it could penetrate the brain. What more you needed? You needed a study to define whether you could combine it with CCNU, combine with temozolomide, and combine with temozolomide. We actually were racing here with the COG group and the Harvard group because COG and Harvard started this study 3 years earlier to this, and we started the study after 3 years. And I was really happy with the way our whole DMG worked. We actually beat both COG and Harvard group in publishing the first result of the phase 1 study of repurposing mebendazole and getting the maximum tolerable dose of mebendazole along with CCNU, along with temozolomide, along with RT and temozolomide, all separate and had different MTD in each of them. The question was whether it would help or not. And this was a poster presentation which was done by Dr. Nandini this year in ASCO, in which we actually went ahead and completed the phase 2 study and presented the results. The study overall came negative, and the reason for that was we enrolled even PS2 and PS3 patients, and our assumptions were based on PS0 and 1 patients. So there is a subgroup analysis which suggests that this might be beneficial. Obviously, this needs more hypothesis testing. This actually got published in eClinical Medicine, which has an impact factor of 20 nearly. And with that, we have actually started now the first phase 3 multicentric study of CCNU mebendazole versus CCNU with a gold standard primary endpoint as overall survival. My colleague Dr. Srinivas from PGI MER Chandigarh will be the lead PI in the study, and it has already got approved from PGI Chandigarh. And PGI, AIMS, Tata, Malabar Cancer Center, and 2 centers from Nepal are trying to collaborate in this project. A lot of other studies did happen in CNS. We looked at the financial toxicities, we looked at the antiemetic prophylaxis, we looked at this was a new OPD to be started with. I do audit my practice, looking at the satisfaction rates of these patients with the OPD and looking at the distress rates this OPD. Mridul was central to all of these studies, and in most of the CNS studies, I didn't have coordinator to start with. Actually, most of my students know that when I initially went, I even didn't have a chamber. I had to start the OPD standing in the corridor of the CNS area. It took 3 years for me to get an allotted chamber, and if it wouldn't have been for this dedicated residents, this won't have been possible. We did something in curative, and I'll show you something in curative. And these are all the ladies who were our MSc students, and all of them were posted with me at some point or the other for 3 months, 4 months, and they were the greatest boon to my research, because they were the one who methodically maintained the files, took consents, follow-up of the patient was done. And actually the lady here, Dr. Ocean, she was a nurse, the long photo, she was the first one to do, and and each of them actually have a first author publication in CNS while they're posting of around 6 months, which they were there with us. We all know the results of RTOG 9802. PCV did show that it was better. But community practice is temozolomide. This is top study. Head-to-head comparison of temozolomide versus PCV. There are only 2 studies going on globally. One has been done by URTC, which is recruiting very slowly. About 36 patients have got recruited. We need 217 patients. One patient got recruited yesterday. So we are, if everything goes according to plan, in another 15 years, because this would require a large amount of follow-up for the events to happen, you would get these results. But I'm not going to show you the results. What I'm going to show you is, if you give PCV properly, and this manuscript is under a review properly, can it be given? The RTOG guy could give it only for 3 cycles of procarbazine and median 4 cycles a month. If you have a good planned neuromedical oncologist giving this regimen, you could see that in Tata we could deliver 5.5, the maximum number is 6, and 6 in CCNU, and Vincristine 5.5. The moral of the story is, if you put heart in giving PCV, this can be deliverable even in Indian settings. Last minute, I'll show you some interesting studies which are going on in CNS. We are trying to repurpose gemcitabine to see whether it could help in meningioma. Satvik did the initial work of this. This was a fantastic study which was conceptualized, and Chandrakanth is here, he was there, and Siddharth was there when this was conceptualized. This was conceptualized pre-COVID. And the reason why this got conceptualized was because patients of CNS had difficulty coming to agent. This was a head-to-head randomized study to check whether clinical follow-up could be replaced by video follow-up. And yes, the study was decisively showed that video don't need clinical follow-up. Video follow-up, whichever way you see it, was better than that. Patients were more satisfied with this, the decisions were similar, and there was a lot of cost cutting which happened, which you could see that the cost of clinical follow-up came out around $131 US, and it came down to $58 US if you could go with this. This whole topic was about CNS and head and neck cancer. But I couldn't disappoint my host, Dr. Vivek. And this is slide for Vivek, because this was the phase 3 study which Vivek presented in ASCO of 2018 of pemetrexed versus arlotinib as a maintenance. I need to thank a lot of funders, without which none of the studies can be done. I am very grateful to Terry Fox Foundation, which repeatedly year and after year finds me credible to give me funding. I need to thank a lot of other things like TRACK, Brain Tumor Foundation of India, CRST Foundation, Motivation Excellence, ICON. ICON has actually sponsored 2 to 3 studies of mine. This wouldn't have been if I didn't have great teachers and mentors like Kumar Prabha sir, Vanita Narona madam, and Amit Joshi sir, and a whole lot of coordinators like Vijay, Kavita, Shushti, who work hard with us, and a whole lot of residents. I have shown you some snapshot of residents. This is routine during ASCO. Sujit is there, Kunjesh is there. They won't get leaves when ASCO is near, you need to do data entry, you need to do analysis, and you need to send papers. And this is the culture we have generated. This is one man many of you would have seen in 108. He is Dr. Sachin Dumali, he was a study coordinator. Unfortunately, we couldn't retain him, and he has gone to ATRAC. He knows head and neck cancers, palliative treatment, as par with Vermocon, I would say, because he has been part of all the studies, knows everything about RASIS, everything about toxicity assessment. I need to thank my neuro DMG, especially Professor Jalali. It's very rare that you have someone coming from outside, coming to the department of neuro, you are giving him space in medical oncology, and within 5 to 6 years, you could see randomized study data coming on. This is not possible without the cooperation of many. I need to thank my colleagues from Malabar Cancer Center, because a lot of work was inspired at Malabar Cancer. Sujit is sitting there. Sujit has been with me in Malabar. Sujit has been with me. And definitely I would have missed some. And that's the reason why I made this slide yesterday. This is the slide of 185 students who had worked with me, and I need to thank each one of them. This wouldn't have been possible without each one of them actually spending their personal lifetime to work with us. I need to thank, there are multiple people here, and I'm sorry if I would have missed someone, but these are all the students. And the last row is special. This is Dr. Prasad, Dr. Bharat. The Tata, we have this culture. I was never a junior because they had left already before them. But every conference I visit, every time I visit them, in fact, it was Bharat's thesis, जिससे मेरा शुभ मुहूर्त हुआ था. That was the first paper I wrote in Tata, and it was really a शुभ मुहूर्त. Today, I have around 550, 570 publications, and that was really a good, what you could say, nariyal to start with. I always find this, that our Tata seniors are very encouraging. They ask what studies are going on, they are interested in knowing, and this is a very phenomenal culture which is there in Tata. I need to thank a lot of lab partners, Dr. Atanu, Dr. Shantam, who has been my teacher, my friend, and my guide, and above all, never acknowledge my wife, and I need to acknowledge her. All the research in India comes at the cost of personal time from 5 to 10. And if it wasn't for her, I couldn't have done it. Thank you.
Can we have the plaque, please? Is Sampada in the audience?
Yeah, Sampada.
Please come here.
Sir, can we request Vivek sir and Chandrakanth sir as well?
Yes, yes. Vivek and Chandrakanth, please hand over the oration plaque to Vijay.
We will have a quick lunch break. We are running a little bit behind schedule, so we will try to finish lunch and come back.
And we'll move on to our next session, which is nutrition and oncology. Our session director for the session is dietitian Anjali Nair, senior nutritionist and dietitian Mumbai, and our chairperson is Dr. Shiv Shankar T, nutritionist and dietitian from Mumbai. So now I invite our session director to please start the session and also to talk on nutrition assessment. Over to you, ma'am.
Good afternoon, all of you. I thank the organizers to invite me for this session today, where I'm talking on nutritional assessment with a case scenario. In my many years of experience, and also today with many scientific evidences, they do state that both cancer and the oncological therapies which are utilized for its treatment can have profound effects on an individual's nutritional status, thereby making nutrition an important component of medical care. Although all patients with cancer are at nutritional risk, as evidenced by the screening, not all patients with cancer can become malnourished. And therefore, first by having the screening done and then using nutritional care process, which includes nutritional assessment, ongoing monitoring and follow-up, are crucial for preventing or minimizing the development of malnutrition at all stages of treatment. Also, it has been long known that patients with cancer experience weight loss and tolerate treatment poorly. Poor nutrition status has been correlated with decreased long-term survival and a factor in exhibiting lack of improvement in treatment outcomes. So now, as a clinician and an onco registered dietitian is responsible for assessing the nutritional status of patients with cancer, having an understanding of potential metabolic impacts of various tumor types and also the possible effects of various oncotherapies. So, in most of the cancer hospitals, I'm sure it goes with the help of a rehabilitation team, including of an oncologist, an onco-nurse, a dietitian, a therapist, and patient's relative and the patient, which help in identifying the nutritional goals and plan ways to help meet them. Today, all the doctors or the oncologists along with the dietitians as panelists who are present around will definitely agree that eating well on treatment helps the patient to feel better, keep up the strength and energy, maintain weight and the body store of nutrients, better tolerate the treatments related side effects, lower the risk of infections, help in healing and faster recovery, thus helping in maximizing the quality of life. Now, for that reason, the regulatory agencies like the Joint Commission on Accreditation of Healthcare Organization and Centers for Medical Care Services require the nutrition screening be performed in all healthcare setups. Nutrition screening refers to the initial clinical evaluation to identify the patient who is at risk for malnutrition. Accurate nutritional screening is a vital support to nutritional care process, and it is not considered as a part of a nutrition care process because it can be conducted by any healthcare professional, and this can be done the moment patient is registered at the hospital level, so that whoever is and healthcare professional can definitely screen this patient. When we talk of screening, it is found that MST is an example, that is malnutrition screening tool, is an example of short nutrition screening tool, and it has been validated in both inpatient and outpatient settings. It has been found that this is highly sensitive and low specific in cancer patients. Now, if you see, this is a format which is used in MST, and it states that whether you have lost weight recently, how much you have lost, and what is your appetite. Whether you are eating poorly, that shows your appetite score. So this total malnutrition screening tool score is only based on weight loss and your appetite score. And it says that if the score is 2 or more, the patient has to be referred to the registered dietitian immediately, so that the dietitian takes part in the nutritional assessment of the patient, giving them with taking the dietary recall, and this helping them to give the proper nutritional interventions. Next slide. Now, as in malnutrition screening, if the patient is at low risk, routine clinical care is given, but the screening is repeated again. If it is at hospital, maybe a weekly screening is done, or if the patient is asked to come for follow-up after 15 days, maybe during that time it is done. And at home care, it can be monthly, and in community, it is done annually. But after screening the patient, in case we find that on dietary recall, if we find that the patient's documentation of dietary intake for 3 days is lower, and if inadequate diet is being taken, that is by considering the appetite score, you can immediately repeat the screening again, and again, as it is said, weekly, home care monthly, and community annually. But at medium risk, immediately after every 8 days, the screening can be done and will help the patient to understand, and after taking the dietary recall and starting on the dietary interventions. But if the patient is at high risk with 2 or more score, immediate reference to the dietitian by the clinician is important for nutritional interventions, and this dietitian can help the patient to set goals for his dietary intake. Next slide. Now, many a times it is asked that why is it MUST, that is malnutrition universal screening tool, is not effective in cancer patients. As studied with MST and MUST, it is found that MUST is with low sensitivity and high specificity, and this is more helpful for the patients with other chronic diseases. Now, main thing in MUST, the addition of BMI score is there. Now this, when BMI score, many of our cancer patients, it does happen that they are edematous, they can have swelling on their feet, they can, it can be hyponatremia, it can be hypertension, or it can be hypoproteinemia, because of which the swelling is there, and where the BMI score differs. So for that reason, it is found that MUST is with low sensitivity and high specificity. Next, so it can't be used for in the onco patients. Next slide. After screening of the patients, after sending the patients or referring the patients to a dietitian, a registered dietitian, it is that person who does nutritional assessment for this patient, for the patient. And it is found that using SGA, which is a subjective global assessment, and this subjective global assessment is a validated tool, especially for cancer patients. And I think in 1995, 1996, this was done by Dr. K. Mohandas, a gastroenterologist, along with Mrunal Shirodkar, and it was found that it is a most validated tool for cancer patients, because this was initially developed to assess patients for malnutrition by utilizing the information that could be obtained without the need of laboratory data, and it is the one which integrates many traditional parameters used in nutritional assessment with clinical status and functional capacity, and also deals with the historical information of weight loss, the dietary intake, GI symptoms, and functional capacity. It also has the metabolic demands underlying the disease and nutritional related physical examination considering loss of subcutaneous fat, presence of muscle wasting, edema, and ascites. So there are around about the score is between 1 to 7, and you can see we have very mild risk to well nourished, which is 6 or 7, mild moderate, that is 3, 4, or 5 ratings, and severely malnourished is 1 or 2 ratings in most of the categories. So on this basis, and with the help of dietary recall, it is the dietitian who actually plans on the nutritional interventions for this patient. And after giving the interventions, it is not where the dietitian's job is stopped, because the monitoring of the patient is definitely important, because we need to understand that the patient is actually following the diet plan or the dietary interventions which are given to him, so that he doesn't get into cachectic stage. And with cachectic stage, he doesn't get into the last stage of his life. So that is why it is always important from screening to nutritional assessment with nutritional interventions, which definitely helps the patient to take his treatment better and helps in giving a positive result. So why this has been started? Because American Dietetic Association adopted this nutrition care process in 2003 as a framework for dietetic professionals to use and support critical thinking and decision making in variety of care settings. And the purpose of this was to improve the consistency and quality of individualized patient care and the predictability of outcomes, with a systemic approach to provide high quality care and standardized model intended to guide a registered dietitian in providing high quality nutrition care. So this nutrition care process is crucial to improve the consistency and the quality of individualized care for patients and improve the predictability of the patient outcomes. There are 4 stages, 4 steps, you can say. The first one is nutritional assessment. And this nutritional assessment is defined as a step which is a method of identifying, evaluating data needed to make decisions about nutritional related problems and diagnosis. Individuals with positive screening results can be referred to a registered dietitian for comprehensive nutritional assessment. And the data is gathered, which is clustered in nutritional assessment, is the nutritional history, that is where the patient talks of the type and amount of food consumed, changes in quality or the quantity of food eaten, maybe reporting the reasons why they are not able to, and achieve through the food record of 24-hour food recall, or and also calculating on the caloric and the protein count. Along with that, if possible, citing on the markers of nutritional status, that is serum hepatic transport proteins, albumin, free albumin, and transferrin, and the anthropometrics like the height, current weight, weight history, usual body weight, mid-arm circumference, and tricep skin fold. Also, while planning of a diet, it
Anjali,
is always essential to have the biochemistry
Anjali,
parameters into
hello,
account.
hello.
Hello.
Can I ask you to go to your last slide, please? The time is over. This is Purvish speaking.
Oh, Dr. Purvish. Yes, but I have to give the patients overview.
No, I think we have run out of time. We cannot continue like this. Please go to your last conclusion.
Oh. So this last conclusion, there are studies which are saying that patient is directly not linking only with nutrition screening, but to improve the outcomes in onco patients, you have to link between screening and the nutrition risk. And there are evidence of improved outcomes in severely malnourished patients with nutritional support. So early effective screening and early identification with proper nutritional assessment can have optimal nutrition intervention which can help you to improve the outcomes, as evidence in the case which I have put up. Thank you.
Thank you, ma'am. We'll now move on to the panel discussion. I now invite Dr. Senthil Rajappa, medical oncologist from Hyderabad, to please moderate the panel discussion on the session. Problems on nutritional assessment. The panelists are Dr. Puresh Parekh, medical oncologist, Mumbai; Dr. Anil Singhvi, medical oncologist, Indore; Dr. Ghanshyam Biswas, medical oncologist, Bhubaneswar; Dr. M.V. Chandrakanth, medical oncologist, Kolkata; dietitian Nazneen Hussain, nutritionist and dietitian, Mumbai; dietitian Shilpa Chadda Thakur, nutritionist and dietitian, Faridabad; dietitian Meena Kumari, nutritionist and dietitian, Faridabad; and dietitian Ritika Sharma, nutrition and dietitian, Delhi. Apologies. And I also request the chairperson to please join the panel. Thank you.
Thanks, Kashish. Good afternoon, everybody. I'm doing a panel on something I've never done a panel on. Okay, Madam is a nutritionist, right? Very good. So the only wise lady of us. All right. So we're running a little short of time, so we'll finish. Pull it
Dr.
back.
Senthil, it is not the wise lady, but it is like with the experience of, and trying to help the patients out. And of course, there are more wiser people than me now.
Agreed, madam. Agreed. Absolutely. Okay. So, our slides are up there. So I thought nutrition and cancer is very similar to Indian democracy. All of us want to go and vote. We know we should vote, but we don't vote. So we all know nutrition is extremely important, but we don't lay the necessary emphasis on doing that appropriately for our patients. I thought we'll start with a few numbers that will help us explain the gravity of the situation better. And a lot of this is actually Western literature. So even in well-to-do economies, 30 to 80% malnourishment, 10 to 20% of mortality is independent of the cancer and is very much dependent upon the nutritional status. In fact, there was a paper some years ago on just the impact of exercise and nutrition in adjuvant therapy of colon cancer, and it gave more benefits than what you get with adjuvant chemotherapy. So very important. And it's got impact on all these cancer outcome parameters: quality of life, adverse events, PFS, OS, resource utilization, because patients who are better nourished are likely to develop complications less, so your usage of resources is less. So Chandrakanth, overlooked, under-prioritized, under-diagnosed, under-treated why is it that we are not emphasizing adequately on, or you're saying, I'm doing, sir, only you're not doing? What is the reason that we are not focusing as much?
So, if we look into cancer, the directly visible cause of morbidity mortality is cancer, which is visible. But nutrition, even though we consider it as the underlying cause, we are not realizing the direct causation. It is not in the consciousness when we see the mortality. We are blaming more of the disease than the nutrition part. So, because we are not able to see that clear visibility of translation of nutrition to morbidity mortality, we are not able to perceive it.
Vivek?
Sir, actually, I feel that the problem is itself in the setup.
Okay.
As an oncologist, when the patient comes, we are referring the patient, you go and meet cardiologist, you go and meet dietitian, you go and meet surgeon.
So are you